Hi everyone, welcome back to Izzy Medicine. Today we're continuing our shock series with this interesting case. It's 3 p.m. when a 28-year-old woman comes in with severe abdominal pain. You notice that she's pale, she's tachycardic at 115, her blood pressure is 85/50, and she reports that she's been soaking through a pad every hour for a week with her menstrual period. Her skin is cool and clammy, she's asking for blankets, her pulse is weak, and she feels dizzy sitting up. You start suspecting that this may be hypovolemic shock. So let's break it down and figure out what it is and how to fix it. In hypovolemic shock, there isn't enough intravascular volume for the heart to maintain circulation because the tank is empty. Why is the tank empty? Cause number one is bleeding. So things such as trauma, a GI bleed, a ruptured aneurysm, or even a very, very heavy period. Second reason is fluid losses, things such as vomiting, diarrhea, burns, diuretics, excessive sweating from overheating. With less returning blood or low preload, which essentially means less blood filling the ventricles, because it's just not there, stroke volume falls. And when the stroke volume falls, because we know that cardiac output equals stroke volume times heart rate, the cardiac output falls as well. This leads to dropping BP and oxygen delivery. So even with a healthy heart, you can't pump what isn't there. The body then compensates through baroreceptors and sympathetic activation. It releases norepinephrine and epinephrine and hormones from the kidneys to raise heart rate, constrict vessels, and retain water. But this shunts blood away from skin and gut to preserve brain and heart. This is why an exam with hypovolemic shock will often see cold, pale, mottled skin, because the blood is getting shunted away towards vital organs, a weak but rapid pulse, because there's not enough preload, so the pulse is weak, but it's rapid as the heart and the body are trying to compensate for the reduction in stroke volume, and dizziness and confusion as the brain is getting low oxygenation from this reduced volume. If uncorrected, tissues switch to anaerobic metabolism because there's no oxygen. In that process, there's a production of lactate and acid, and this lactic acidosis can lead to multi-organ failure and eventually death if we don't correct it. When we suspect hypovolemic shock, we check early markers for poor perfusion. So we draw lactate, and if it's above 2, that's a concern for shock, and if it's above 4, that's already a concern for severe shock. We also check a base deficit, and that's done through arterial blood gases or venous blood gases. And if we see more than -4 or more negative than -4 on blood gas, that's a concern for poor perfusion. Additionally, a shock index, which is normally between 0.5 and 0.7, if it's above 1, that's a concern. How do we calculate shock index? It's essentially heart rate over systolic blood pressure. Our patient has a heart rate of 115 and a systolic of 85, which means she has an SI of 1.35, and that's concerning. We don't just stop at these markers of poor perfusion. We also order labs to confirm and find the cause. We order a CBC to look for anemia or hemoconcentration. We look at electrolytes. We look at BUN creatinine to look at kidney function and see if there's damage. We check glucose because low glucose and high glucose can affect outcomes. LFTs because elevated transaminases can signal that there's poor perfusion and ischemia at the liver. We check the urinalysis to look for dehydration and also type and screen and cross-match in the case that our patient may need blood products. How do we fix it? Essentially, we replace what's missing and we stop the loss. If it's fluid loss, we give balanced crystalloids, such as lactated ringers or plasma light. We start with a bolus of 20 to 25 mLs per kilogram rapidly, and we reassess every 10 to 15 minutes. We have to be careful to not overdo it, because too much crystalloid can cause pulmonary edema, it can cause dilutional coagulopathy, it can cause compartment syndrome and electrolyte imbalances. So in order to not overdo it, we use clear endpoints to guide resuscitation. We look for improved mental status. We look for a urine output that's between 0.5 to 1 ml per kilogram per hour, about 30 to 50 mLs per hour. We look for the lactate to drop more than 20% in about 2 to 6 hours on serial rechecks, and we look for the base deficit to be trending towards 0 on serial blood gases. Also, we want the capillary refill to improve to see that our patient is retaining hydration and for the capillary refill to be under 2 seconds. It's important to note that if you've already given about 3 to 4 liters in a non-bleeding patient and they're not improving, we should reassess the diagnosis and look for other causes of shock. On the other hand, if it's blood loss, we start with a small crystalloid bolus of 500 to 1,000 mLs, all while concurrently arranging for blood products and controlling the bleeding. We begin fluids and bleeding control in parallel. We don't wait. Again, here, we avoid excessive crystalloids because they dilute clotting factors and worsen coagulopathy. How do we know in this process when to switch to blood? So if our patient is still unstable after the initial fluid bolus, if the hemoglobin is under 7 or under 9 with cardiac disease, if there's ongoing bleeding that we haven't been able to stop yet, or a worsening shock index. When giving blood, we start with packed red blood cells, but if we've given more than 2 units, then we switch to a 1:1:1 balanced transfusion, which includes packed red blood cells, fresh frozen plasma, and platelets. What we try to do is use type-specific and cross-match blood when possible. If it's urgent, it's O negative for women of childbearing age and O positive otherwise. As a side note that's important, in trauma without brain injury, we practice what's called permissive hypotension, where we hold the systolic blood pressure between 80 and 90 until bleeding is controlled. This is because we want to maintain just enough perfusion for the brain to get oxygenation, but not so high that we dislodge the clots that are being formed and help control bleeding. If the patient does have trauma and brain injury, then we maintain normal blood pressure if that's suspected. It is often asked, what role do vasopressors have in hypovolemic shock? Well, it's not first-line therapy. We only use vasopressors as a bridge if hypotension persists despite adequate volume, but we must fill the tank first. So to recap, lactate and base deficits rise before BP falls, so we have to check early and act early. If you're already thinking about a 3rd liter of crystalloids in a bleeding patient, you're already late. We have to start blood products early. And fluid for fluid loss and blood for blood loss. So that's that. This is hypovolemic shock in a jiffy. I hope you are able to recognize it early, act quickly, and use clear endpoints to guide resuscitation. Thank you for watching Izzy Medicine. If you liked this, please click like, subscribe, and check out our next videos in this series. Until next time, stay calm and keep saving lives. Bye.